Good morning, everyone. We welcome to the Presidential Symposium, which this year is entitled Predicting the Future of Epilepsy, or should be in Epilepsy, which is a bit of an ambitious title, and that is precisely what we're going to address today with very interesting presentations, as you can see in the program. And we will have questions after every presentation rather than at the end, so that they're fresh in our minds and we can address them. And without further ado, I would like to invite our first speaker, Dr. Lara Jahi, who is going to talk about algorithms in clinical practice. Can they really help us predict outcomes? Can you introduce the next one?
Thank you, Dr. Wiebe and Dr. Brodie, for the invitation. It's a privilege and an honor to be standing up here today to talk to all of you on algorithms in clinical practice and answer the question of can they really help us predict outcomes. A general roadmap, we will first define what is an algorithm, go on to why do we need an algorithm, or many in epilepsy, and how can we use them. So what is an algorithm? The simplest definition is this. It's a step-by-step procedure for solving a problem or accomplishing some end. So let's talk about an end that every one of us in this room had to accomplish to get here. We all needed to get to Bangkok somehow. For some of us, the steps that they needed to go through were less than others. Yet, we all had to do a similar thing. How would we have done this without algorithms? How would we have done this if we were living, say, 30 years ago? We would have found a nice, helpful travel agent. We would have had to pick up many big paper maps to review the directions of how to get to where we need to go. We would have gone to the library or bought some travel guides and travel books and had to look at them to see what's interesting besides the International Epilepsy Congress to go see in Bangkok. And if we had to give a talk, we would have drowned in books and articles and things that we had to read in order to find the information that we needed to find to put together in our slides. I don't think anyone in this room did this before they got here. What we probably mostly did now with algorithms is you just go to a travel website, I put in Cleveland going to Bangkok, and I came up with many suggestions for how to get there. I used my phone to find the route to get to the airport and to find my way here. You go to a website, TripAdvisor in my case, to help you find interesting things to do, and those are all filtered by many more criteria besides the things that you can remember for things that you wanted to do. And I definitely Googled what is an algorithm when I was preparing for this talk. So, how about another end that many people in this room, if not all of us, have to accomplish? How do we decide the type of epilepsy surgery that we offer to our patients, whether it is in Cleveland or in Bangkok? This is how we did it 30 years ago. We would get together in multidisciplinary patient management conferences, and we would have a discussion about the surgical choice to make, and we would come up with a decision. How do we do it now? We do it exactly the same way. The faces change, but the method is the same. There is something unusual with this, no? In a way, we are using algorithms everywhere in our life, except in our job, except in the way we are delivering care in epilepsy. It is as if we are using a flip phone at work, but we are using the smartest smartphone in everything else that we do in our life. And somehow we think that that's okay. So that's why the idea that there needs to be a talk to convince people that algorithms are necessary in order for us to do a better job sounds a bit out of context when we are using algorithms in everything else that we do. So I hope it is obvious to people that at least there is a need for us to go from using gut feelings and intuition in the way that we practice our medicine in epilepsy to evidence, and that this move from gut feelings to evidence should really be the future. So some of you may say, well, it's not really necessary because for all these other things that we discussed, how we find our way, how we find interesting things to do, there was a need for improvement, so that's why technology and algorithms had to come in to improve how we do things. But there is already an algorithm that we follow in epilepsy surgery. We have steps that we go through in order to make our decisions. And in fact, that is true. So what are the steps, the current algorithm, that we follow to achieve and maintain seizure freedom? The first step is we have to find epilepsy surgery candidates. We have to find their epilepsy, localize it, then we remove it, and then, voila, we make a patient seizure-free. That is our end that we want to accomplish, and these are the steps that we go through. To find the candidates, there is a wealth of information that's out there. Don't bother reading the individual lines on that slide. The point from it is to communicate that there are a lot of outcome predictors that are available to help us identify patients who are good surgical candidates. So the knowledge is out there, we think. What we need to find those patients that will benefit from surgery has definitely been published. And these are articles that anybody can read. So there are multiple outcome determinants. How about finding the epilepsy? We've also made tremendous progress there. There are very detailed pre-surgical tests that are at our disposal right now. There is sophisticated imaging that can be done that's getting more and more improved. There is invasive EEG technology that we can use to help us localize. Right now, we're at the point where we can pretty much map many networks in the brain. So we are making, again, a lot of progress using algorithms in the steps of finding the epilepsy. How about the last step? How do we decide what to remove? That step is one that has been stuck in the mode of intuition and thoughtful process evaluation without any change, like we've seen with all of the other steps that we illustrated. And the goal that we are wanting to attain is still suboptimal. These are Kaplan-Meier curves that show us long-term outcomes after the most common types of epilepsy surgery that we do. And you can see that close to half of our patients are continuing to have seizures years after having their resection. So if our algorithm is successful, how come we are not getting the end that we want to accomplish? And I would argue that this is exactly why we need a new algorithm in our care and decision-making process for epilepsy, because despite the tremendous strides and progress that we've made over the years in our epilepsy localizing technology, where we started off in the 50s with just EEGs and pneumoencephalograms, and we have now a tremendous wealth of tools at our disposal to localize the epilepsy, our decision-making component has not kept up with the evolution, obviously. And our decisions are still largely intuitive. And for those who think that that's not a problem, let me share with you an experiment that we did. We took 25 actual cases, patients who went on to have epilepsy surgery, and presented them to, so 20 actual cases, and presented them to 25 different specialists, experienced epileptologists. And we asked them one simple question. If you had 100 cases, just like this one, how many do you think will be seizure-free in 2 years after surgery? This is case 1, and you can see that if I was, say, case 1, going to see these specialists, I would get anywhere from 30% all the way up to 80% as far as my chance of becoming seizure-free with surgery. You can imagine that I would jump to schedule the appointment with the surgeon in one situation, whereas in the other situation, I would just walk out the door. And I'm me, I'm the same patient. And this is the spread of our expert decision-making when it comes to using our own intuition. And what happened to the other 19 cases? We were all over the place. What you have here is these are called violin plots. This is for the 2-year prediction, and this is for the 5-year prediction. The spread is shown by how far the plot goes, and the green plots are the ones that correspond to patients who are actually seizure-free. The white ones are patients who did not become seizure-free with surgery. And essentially what this says is that our predictions have nothing to do with each other and have nothing to do with reality. And that may come as a surprise because we think of the process of medical decision-making and outcome prediction as being a process that is logical and rational, where the accumulation of knowledge improves the decision that we make, and where past experience improves judgment, and where collective decisions are more reliable. This is what intuitively we all think. That's why we think we are invincibles as the physicians. And to that I say, really, there is a wealth of knowledge, a wealth of literature that actually disproves each one of these points up there. This is the first problem with these assumptions. There are multiple biases. The list of biases is actually 5 times as long as this, but I just wanted to communicate the point that there are many biases that prevent us from making an as objective of a medical decision and a medical prediction as we can. For example, take this availability bias. Who in this room has not heard one of their colleagues or even themselves say at some point, I remember seeing a patient exactly like this one that you're presenting and you're talking to me about right now, and this is what I did for them, and I think this is what you should do for this one. I go by the information that's available to me. The second problem is that of feedback. And that I found to be the most interesting one. What does feedback have to do with us learning how to make better decisions and better outcome predictions? The literature says that there are 2 major categories of learning environments. There is one that's the kind learning environment, and this has nothing to do with having a nice teacher that is friendly. A kind learning environment is one where the feedback is clear, immediate, and unbiased by the prediction. A good example of that is weather predictions. Whatever I see on my weather app if it tells me that it should either say it's either sunny or it's raining. It cannot be somewhere in between. That's a clear feedback, and it's immediate. I see it on my phone, I look out the window or I step outside, and I know if that prediction is accurate or not. And no matter what this says, it has nothing to do with what the sun is going to do outside. So the prediction is not biasing the outcome. So that's pretty clear. A wicked learning environment is one where the feedback is slow, unclear, and may change because of the prediction. So think of the issue of a slow feedback. What happens if that feedback is not immediate? If I'm trying to learn how to shoot an arrow and hit a target, I need to see the target, no? Otherwise, if I'm seeing it, then I know how to position the bow, I know how far back to pull, and if it doesn't work, I immediately know it didn't work, and I adjust. But if I'm shooting in the dark, whether it's just me who's shooting or whether I have a group of experts like me and we are all wanting to shoot that arrow and hit the target, except we're not seeing the target. What we have is our arrow and our bow, and a couple of us decide that it is better to do it this way or it's better to do it that way. We can keep practicing until we have the same feeling for how far back we pulled, or the same feeling for how straight that bow was. But what that does is it makes us become more confident in what we're doing. We become more consistent in how we're doing it, but that has nothing to do with how accurate we are. When we are sitting in a patient management conference as a group of experts, and we are deciding that this type of surgery should work better than that type of surgery now, and we are not learning of whether we made the right choice or not until 6 months or a year or 2 years later, we are just shooting in the dark. And we become more consistent among each other, but we are not learning how to better hit our target. The third problem is one that is, I think, easier to grasp, which is that research and clinical care now go in separate paths. We see patients, we perform our clinical care on them, and yet we decide to do a research project separately, and then we collect our research data separately. In my program, for example, we see 3,000 patients per year, and we do that year in, year out, and then somebody decides they want to do a retrospective study to look at a population that has X disease. We end up going to pull all the charts, look at the data, and then collect that information. All of that information is our clinical care. And that's why there is a tremendous waste of missed opportunities where we are not learning as much as we should from all of that clinical information that we are collecting. And that's why there is this idea of a learning health system where all of the information that we collect within the context of our routine clinical care should actually be incorporated and used in research, in analytics, in predictive modeling to develop algorithms that should help us provide better care. So to bring all of this back to the context of how we care for our patients with epilepsy and we predict our outcomes, what should we do differently? We need algorithms to help us deliver better care. There have been, in fact, many emerging online prediction tools with major clinical usefulness. This is one that Dr. Jotei developed with her team to help identify the feasibility, the appropriateness of an epilepsy surgery evaluation. This is another one that came up a couple of years ago, looking at individualized prediction of seizure freedom after withdrawal of seizure medications. This, however, was the first nomogram that was published in epilepsy surgery prediction, and it's one where we used close to 1,400 patients. We used 800 patients from Cleveland Clinic to develop a model for individualized risk prediction, and we validated that in about 600 patients from Mayo Clinic, Italy, and France and Brazil. And this is the paper form of it, where using simple clinical characteristics like the epilepsy duration, seizure frequency, gender, convulsions, cause of seizures, the model spreads them out along these horizontal lines here, where for each patient that you see, you could pick what corresponds to them. You draw these arrows that go upwards to give them a certain point number, you add that up, that's the total points. You draw the line down, and you get the 2-year and the 5-year probability of seizure freedom. I'm sure nobody in this room wants to use rulers anymore and draw arrows up and down to do this. So this tool exists in an online form where you go to that website and you input for that specific patient that you're seeing their clinical characteristics. And then what that gives you, it gives you an individualized prediction for that patient for their chances of becoming seizure-free. The point here is that every patient is an individual. And to continue to give people predictions based on 600, 500 patient Kaplan-Meier derived curves that just go over the average outcome for the whole cohort when patients don't really fall in clean buckets of either all bad or all good outcome predictors, is not really going to give them what they need as far as their individualized chance of becoming seizure-free. We are now in the process of improving on that nomogram by adding qualitative and quantitative variables that take into account things like EEG, MRI, family history, and genetics, so that we can see how we can improve on this ability of individualized outcome prediction, learning from things beyond the simple clinical variables, right? When you're choosing what restaurant to go to, you have no problem using an app that uses things like where are you now, where do you want to go, what kind of food you eat, what time is the restaurant open, what time does it close, what kind of service there is, and then read the individual reviews and then decide. So there is no reason why we can't use all of the information in our patients to make decisions. This is the last nomogram I'm going to show, one that we developed to help predict naming decline after surgery. And you can see that it has an area under the curve of close up to 0.8. This is, again, the spread of it linearly, but you can also do it online. So in conclusion, our future, hopefully, is one where there will always be room for gut feelings and intuition, because we definitely need them. We want to honor them. But hopefully, it is one where algorithms can help our guesses be more educated, and where the science of algorithms and predictive modeling can help inform our outcome prediction and decision-making process. Thank you.
Thank you very much. Very stimulating, very thought-provoking. Can we have a few questions, please? Just speak when you get to the microphone, because it's quite hard to see into the corners. Yep.
Oh, thank you. It's good that you showed the picture of Albert Einstein at the end.
Yes.
And as a physicist, I must say, not a physician, a physicist, I must say that
Can you get a little closer to the microphone, please?
There is something more fundamental than algorithms, and these are theories and models of the events. And I think that is one of the perhaps biggest challenges here, that we don't have an equivocal or universal model of the epileptic condition. Mm-hmm. And that is a little bit what is an obstruction of building an equivocal algorithm to show the problem. So they are algorithms, but they're still based on some kind of intuitive, evidence-based knowledge.
Sure, and the point that you're bringing up is one that is actually fairly critical in this. It's that to predict something, that thing has to be clear, no? Like, it needs to be ascertained in a way that is unequivocal. So a good way to start is to start with the unequivocal outcomes that are easy to ascertain. So seizure freedom after surgery, for example, is one. A patient is either seizure-free or they're not. Naming decline after surgery is also pretty clear. We have neuropsych measures that we can administer and objectively measure the extent of decline that patients went through, and that either happened or it didn't. So I didn't show any algorithms here to predict epilepsy localization or to map the network. What I showed are nomograms to help us predict these well-defined, clinically significant outcomes that patients care about. So that would be the place I propose to start.
Hi, Lara. I'm Ana
Hi.
Velasco from Mexico City.
Yes, Ana.
Nice talk. How do you introduce the variable of surgery, for example, seizure extension or combined procedures?
Yes, so that is falling under the next steps, what I hope we can take this to, where the type of surgery that one may propose becomes a variable in the model, right? So the immediate goal is to predict whether a surgery that we're doing is going to work. But the ultimate goal would be one where we can use all of this knowledge to help us know ahead of time, before the surgery, what would be the ideal surgical approach for a given patient, right? So that is the holy grail, and hopefully we will get there. I know we will get there. We just need to take it one step at a time.
Thank you.
Thank you very much, and thank you for a most interesting talk.
Thank you.
The next presentation is from Mark Cook, Intelligent Neurodevices, Present and Future. And we'll try and keep the presentations to around 20 minutes to allow time for discussion and questions.
Thank you very much, and thanks again for the invitation to speak today. Apologies, I arrived here at 8 o'clock with a delayed flight, so if there's any brief brain lapses, they're not epileptic. Probably.
Probably.
And this audience knows, of course, that epilepsy is a very serious problem with a high incidence and a great cost. And I'm going to speak a little bit about devices and their use in prediction, as well as some other applications. But the unpredictable nature of seizures represents the major clinical disability often. And there's a big gap because whilst a lot of drugs have evolved over recent decades, we still have, as in Gower's time, 30% of patients not adequately controlled by available agents. So we do need new drugs, and just as a bit of a prequel to this, there's been much interest in dogs and predicting seizures, and I was interested to see this work recently in scientific reports describing how dogs can detect in urine and sweat presumably chemicals excreted during seizures. So not a prediction yet, but an interesting point. So the NeuroVista study is where we started with devices, and the NeuroVista study was a seizure prediction study where an intracranial set of electrodes was placed and a subclavicular implant used to transmit EEG data continuously to a handheld unit that provided the patient a warning of the likelihood of seizures in the hours ahead. And various features were extracted from the EEG and used to predict seizures. And what wasn't used, and this turns out to be important, were time of day and long-term memory and the knowledge of last seizure occurrence, but I'll come back to why these are important in these devices. And this worked. So here the 15 patients who were included in that trial, you can see that we got 100% prediction rates in some of the patients and pretty good prediction rates in others, and there were patients who at the time of first analysis we couldn't accurately predict seizures for, but it did show that with an implanted device you could successfully predict seizures in patients with epilepsy, and in timeframes of ranging between 8 minutes and 4 hours. So these were clinically useful timeframes. But we found lots of other things that were unexpected, such as different populations of seizures. So this graph represents the duration of seizures plotted logarithmically against years on the X scale there, showing the patients had seizures that fell into these very distinctive populations. And this individuality of the seizures and their distributions between the patients was very dramatic and affected all aspects of the study. And Philippa, who's here today, has done a lot of work around these seizure cycles over the last few years. and examined not only the differences in distribution of seizure times, but the distribution diurnally of the seizures and, of course, across longer time frames. And we recognised that the patients, when data was collected over very long periods, had seizures which occupied very particular times of the day often, and there were often times when they never had seizures. And this rhythmicity was an important feature not only of the seizures themselves, but also of the spiking activity behind them. Very importantly, these rhythms spread not only over minutes and hours and across the course of a day, but across weeks and months of time, and probably longer periods too, except that we don't have very long duration data yet. We could see also that seizure activity did relate to spiking activities and other EEG features, but in unpredictable way, well, not unpredictable in ways that we perhaps hadn't anticipated, where seizures represented by the red dots here seem to occur on the rising phase of spike activity, for example. Now, systems have been devised, such as the NeuroPace system, which can be implanted chronically and which record seizure activity, as well as provide therapeutic stimulus. And these have also demonstrated that there are these rhythms in the background of the seizure activity. And so we know that this is a bona fide phenomenon, and more work will be presented on that later this morning by Maxime Baud. So can we forecast seizures using these devices? Again, using the distribution of the seizures during the diurnal variation that we've shown, we can create these gauges, much as we've just seen. We can use, like a weather app, a system that might provide patients on their phone or a similar system an indication of how likely seizures are in the hours ahead. And these systems can be merged using these Bayesian systems, which continuously correct for prior observations and allow very accurate observations of seizure activity. And intriguingly, it might be possible to generate similar levels of prediction from wearable devices. Of course, we'd studied this in a relatively small cohort of patients with the 15 NeuroVista patients studied, and so we approached Seizure Tracker in the States, who have a large body of data from an app used to diarise seizures, and because they had over 10,000 patients with up to 10 years of data, we were able to look at this data and see if it were possible to find the same rhythms. So these are logged by the patients themselves. And we were looking to see whether there were rhythms over the course of the week, whether certain days were more liable to have seizures, and whether certain weeks of the month were more liable, as well as the daily cycles that we'd already found in the NeuroVista patients. And certainly we could determine these. So here, shown in these radial histograms, you can see for a patient that seizures occur at a particular time of day with greater probability, a particular day of week with greater probability, and a greater probability on certain weeks of the month. And again, these patterns were extremely individual. And here's a raster plot showing for the 1,200 patients who we took from the seizure tracker data who had sufficient numbers of seizures to allow us to make these estimations. We can see that there are very strong rhythms at about 12 hours, very, very strong at about a day, and even important rhythms out at a week. But all these blue marks out here represent statistically significant cycles for individual patients. So everyone's different. There are some strong background rhythms, but devices allow us to extract this sort of information and understand better how perhaps epilepsy works, so that we can see a large proportion of patients had at least one cycle, and many had more than one cycle, and that there were a lot of patients with cycles out over 3 weeks, both men and women. Other features that we can look at with devices of this kind include features as critical slowing. So Matthias Maturana is a postdoc working on this, examining for a phenomenon called critical slowing, which is a change we can observe in many natural systems, including EEGs, where electrical phenomena relate to the proximity the system has to a tipping point where it changes states. This is shown here. If we can imagine this black line down here represents the state of excitability of brain. When it gets to a certain critical point, a seizure will occur. It could occur anywhere down here, but it will take a greater degree of energy to push the resting brain state across to a seizure state down here as compared to up here. but we can measure our proximity to this state using these phenomena of signal variance and autocorrelation. And we find exactly the same as I'd shown you with the information that Philip had extracted from our cycle data, that there are long and slow cycles which are separate from those I've described, affecting this critical slowing phenomenon that also let us predict seizures. And these can be combined so that we can take the rising phase of the short and long cycles and estimate the probability of seizures and see that this is very strongly correlated with particular features of this cycle. So again, all of these features can be extracted with a device, and here testing this against seizure prediction, we can see that it performs very well. So distinguishing between these types of transitions is still difficult, and one way perhaps of doing that is with probing the brain directly, so using a different system, so using a MEDTRONIC system, a PC plus S system where we can stimulate and record brain, in this case both in hippocampus and the anterior thalamic nucleus bilaterally. We can record the response to a probing stimulus and measure directly proximity to seizure activity and other phenomena that relate to the state change brought about through stimulation. And this might let us provide prediction about who is going to respond to these brain stimulating devices, and more importantly, let us tune the best stimuli to provide. And we're having a great degree of success with this at the moment using these systems. If we know when seizures are going to happen, then we can provide stimulation more effectively, potentially, to stop it. So here, I'll show you in this animal model. So this is a canine model where we're providing electrical stimulation. You'll see probing responses, a maximal electroshock providing an after discharge, another probing stimulus, and then some deep brain stimulation, after which a maximal electroshock won't be able to elicit an after discharge. So if we're able to anticipate with these implanted devices changes that let us guess how close we are to a seizure, then stimulation could be provided potentially only when it's necessary. So other systems are developing which will let us collect this sort of brain activity without the degree of invasiveness that we've seen so far. EEG have an implanted sub-scalp system which has recently been approved in the European Union as a monitoring device to be implanted under the scalp and non-invasively or minimally invasively record EEG continuously, much as I've shown you from the Neurovista system. MEDTRONIC have been modifying their link system. This is a cardiac device which is normally implanted to chronically record cardiac activity, but here's some work showing with a link device implanted under the scalp, in this case of a sheep, that it can very reliably capture activity seen here collected from the invasive system, very accurately reproducing the hippocampal spikes which are occurring. So these sub-scalp based systems might also be able to provide us similar levels of accuracy. This is a device we've been working on. This is the EpiMinder device, which is also a sub-scalp based system, also intended to collect EEG activity continuously and stream it to a mobile phone for analysis. And these systems can be hooked up to the sort of machine learning systems that we've heard described in the talk prior, where the information can be aggregated, analysed quickly, and feedback provided directly to the patients. Ultimately, by combining these with apps, information about lifestyle, information about climatic conditions and other environmental factors which seem to influence seizures, very powerful systems can be generated. Other types of devices that don't involve electrical stimulation are those such as this intraventricular drug delivery system. So here we see intra-abdominal pump. So this is a pump such as is used to treat chronic pain and deliver drug to the spinal cord. But in this case, we've implanted two catheters, one for sampling CSF and the other to deliver drug to the CSF. We can see in this contrast study here, which provides drug to CSF, which distributes over brain very quickly and evenly, and use this to treat chronic epilepsy. So a device like this might be implanted to provide a medication like this, and we can see these therapies are extremely effective. So this is work currently underway with Cerebral Therapeutics at our hospital. You can see here the drug dose and the seizure improvement, the seizures represented by the orange line. You can see also that when the pump stops delivering medication, the seizures quickly return. So these devices can be inserted, provide excellent therapy, and seem to be very well tolerated, and conceivably could be linked to the sort of predictive systems that I've described. So intelligent neuro devices are providing not only new insights into epilepsy, but also new ways of treating epilepsy. With these systems, it's possible to predict epilepsy, and we've seen that cycles are critical in epilepsy and help prediction, and also help us understand the processes underlying this condition. So far, it seems the critical slowing that I've shown you might be the most important predictor that we've come across, but it's still early days yet. I guess the most important part of all of this is that the features of all of this to each individual are extremely variable and need to be tailored to every patient. But understanding through these sorts of systems the variability in responses to stimulation and controlling this will be critical in our improved therapies. Key to all of this, of course, is collecting the massive amounts of data which we're now able to handle and analyse. Just a quick plug for the epilepsy ecosystem that Levin Kuhlman manages, which sprung for some work on Kaggle contests and other activities. If I can encourage you, it's a good data sharing platform for epilepsy and to work on improving the algorithms that we've developed along with others for the seizure prediction methods. Also Dean Freestone, who's been so important in this work, and other contributors from both national and international groups. So thank you very much.
Thank you very much for a very interesting presentation and the ability to summarize such an extensive and interesting field in 13 minutes is fantastic. So that leaves a very good time for questions, and I think that there will be lots in this topic. So we have a person over there at the microphone.
So I just have a question of the app that you showed where the patient is putting in individual data. And my question is about compliance and whether you have any data how compliant patients are with filling out questionnaires.
So that data we've showed you is from Seizure Tracker. We've been collecting data as well, different data. I guess the important point there is, and we know patients are very unreliable with these things, and there's fatigue with diaries and with the electronic systems over time. I guess we selected for that study, you'll see a subset of the patients involved with whom reporting seemed to be pretty compliant, and we had good numbers of seizures. But I think the key to it was, and Philippa might like to elaborate on this, the key to it was having patients who had great numbers of seizures, because if they had very large numbers of seizures, then compliance and errors around reporting became less important.
Okay, thank you.
It is a problem, though.
Thank you. We have another question here.
Hello. How is this data compared to the NeuroPace data that's coming out?
The data around cycles, it's very similar data. I mean, with the NeuroPace data, of course, is collecting time-stamped data because they've got less opportunity to collect EEG in the way that we did in the NeuroVista study. But nevertheless, the findings are almost identical. So these cycles seem quite consistent across the various studies now which have looked at it.
And a second question, how can you incorporate the environmental data, for example, moon cycling, and all the information that we keep hearing, but we have not been able to have a precise method for studying it? Are you taking a look at that?
Yes, so I can give you an example. I haven't shown this data because I didn't think I'd have enough time, but we had information, for instance, around the weather with the NeuroVista device because the patients had an implanted device and we knew where they were, and so we were able to lock them to meteorological data, and so we could see that there's variation in various features like their spikes and seizures, and whether their seizures were clinically manifest that related to temperature, it related to humidity, and it related to many other factors. This is still pretty preliminary work, and there are many caveats yet, but environmental factors do seem to influence seizure activity considerably. Not the moon that we've been able to establish, but you never know. We might need more data for that.
Yes, but the patients can keep asking, and when we're in our outpatient consultation, well, they do come more frequently. Thank you.
Yeah, I guess one point not directly related is that we did find 4 weekly cycles just as often in men as women.
Of course.
So,
like if it was catamenial.
indeed, yeah.
No,
Thank you very much. Any other questions from the floor? There you go. Yes, please.
Fantastic work. I was interested to know whether patients can learn from having the neurophysiological monitoring the signals within themselves that can predict a seizure. So after a period of time, they might be less reliant on the device and more reliant on things that they can do themselves to prevent seizures.
I think that's absolutely right, and we all know about simple things like sleep and so forth, and advising patients with regard to that, but there are probably many other factors, and I guess one striking thing about the data that we've recovered is that it's often not apparent to the patient, much less the clinician, that there are these very strong cycles and that seizures are only occurring at particular times. So identifying that for a start could be very useful for patients. But I think there are many other factors which they could usefully include in these systems. I guess one potential complication might be, as we heard in the earlier talk, with a wicked data set is where what you're measuring is influencing the outcome. And so the other possibility is having this prediction actually influences the likelihood of seizures. Certainly some patients strongly feel that just knowing the likelihood of a seizure might affect the likelihood of a seizure. So there are many other factors which I think we have yet to explore.
Yes, thank you very much.
Thank you.
Thank you, Professor Cook. Our next presenter is Dr. Philip Rivlin from Switzerland, and he will be addressing the topic of machine learning and artificial intelligence, and is the future already here? Philip.
Thank you.
20 minutes.
20 minutes, and prepare your smartphone. There will be a few questions. So this is a summary of my presentation. I'll spend a few seconds on definition about artificial intelligence and machine learning. Then a little bit more time trying to see what the current landscape of using this technology in healthcare in general. We have a lot to learn from other fields. And of course, we'll discuss what's happening in epilepsy and end up with the many challenges that we're facing when willing to develop those technologies in epilepsy. So, definition first. Well, obviously, difference between machine learning and deep learning. For deep learning, you need to have a belly, and that makes me feel very good. I guess the chair also must feel good today. And I'm going to ask you the first question about this, deep learning. I just sent the vote. Those are the proposals. Is it a form of artificial intelligence? Is it a form of machine learning? Is it very important at pattern recognition? Do you need to use multiple layers to extract different level features from raw input? And for those who think those are two easy questions, there's the last one. Can it be interpreted in terms of the universal approximation theorem? Okay. I don't see the vote.
How can people vote?
Finality, is it running? Okay. Okay, I got the vote, and you should see them too, and I will share them with you. So basically, it has been 20% for question 2 and 3, and 50% for 4, and 10% for 5. All the responses were correct. All the responses were correct. So, indeed, artificial intelligence. It's part of computer science, primarily tackling objectives that or process that are associated with human intelligence or behavior, and of course that include learning. Many different types of learning are considered. We're just going to discuss machine learning and deep learning. There are others, but also language and chatbot that are becoming more and more popular, including in healthcare, are part of artificial intelligence. Machine learning is really about having your system learning from the data without directly programming the analytic you want it to perform. So, a concrete example, you want to detect seizure. With a classic program, you will have to explain that an ictal EEG starts with hypersynchrony, specific frequency, specific amplitude, and that will help a classic system to detect the seizure. Here you will just give the EEG to the machine learning system, and you may or may not indicate when the seizures start to learn from a number of examples, and the system will then figure out what are the features that distinguish the seizure from the interictal state. Deep learning is just a form of machine learning that is a little bit more complex. It will use multiple layers to be able to detect different hierarchy of features hidden in the data. And then we also consider both supervised and unsupervised learning to make it simple, and taking again the example of EEG, supervised will be that example where you give the input, the data, but also some element of the output. That means you will annotate when the seizures start for the machine learning to learn how to recognize it. And then the machine learning will provide you with some predictive model, either using classification or regression analysis. Unsupervised learning, you will just give the EEG and then see how the system can clusterize all those data. You might find different cluster according as to whether the EEG come from a male or a female, during sleep, during awakeness, from a person with epilepsy or not, or distinguish segment with seizure or non-seizure, or maybe all of this. It will be up to him. I thank Nathalie Jette for sending us this paper yesterday, because I had missed it previously. It's very recent and interesting. It's just to point out that for some application, at the moment, there might not necessarily be superiority of machine learning as compared to classic statistic, here logistic regression, and at least when performing a prediction model, like the one that were discussed by Lara for epilepsy surgery in the first place. I'm not going into the detail, but basically what the funnel plot is showing is that there is no difference in performance in that systematic review between the two approaches. But there's other field where obviously AI will have an advantage. It can apply to many, many aspects of healthcare, from birth to death, and all those illustrated here actually are already ongoing, either being evaluated or already implemented in some healthcare. And you can distinguish three types of activity. One is triage and screening, very repetitive activities for which we often don't have the human resources. That's typically what the chatbot are doing, and that's, of course, potentially useful. The replacement scenario is more about analyzing medical imaging, for instance, with the view that the AI tool will perform a better job than the physician and replace them. And the augmentation of human provider will be more like the classifying or identification of novel biomarker on top of what we already know, so that will come in synergy with our current knowledge and practice to increase the quality of care. A few examples, very few examples. In pattern recognition, which is really where AI and machine learning is the most effective at present. So looking at an image, whether it's an X-ray, a CT scan, histology, a skin photograph, or even a EKG or an EEG. Interesting figure, it has been estimated that AI to process 250 million images will cost only $1,000 in terms of processing. We can see here the pathway to the Uberization of radiology. And don't worry, it's going to be the same for EEG sooner or later. A few, example of what has been done, X-rays analysis for cancer, comparing the performance of AI to well-trained radiologists. So the gold standard to estimate the performance of those machine learning is a so-called OROC for area under the receiving operating curve. When you're above 0.9, it's really, really good. And in that case, it outperformed most of the radiologists. Another example for CT scan for acute brain lesion, there you see that the OROC is lower, 0.7, it's not that good. It's there, but not that good. But the system was much faster than the radiologist, a little bit less accurate. Pathology, it's also a place where this can be extremely powerful, and more recently, there's also has been this report on dealing with DNA methylation quantification and analysis, which is quite complex. And based on those findings, they could reclassify brain tumors, and that appeared at a paper in Nature last year. Looking at the photograph for melanoma, here again you see a high performance that was better than that of 58 international experts. And we'll say a few words about what can be done with electrophysiology. And definitely wearable chronic EKG now can detect atrial fibrillation with a sensitivity which is very close to that of the implantable Rivlin system that Mark just mentioned previously. There are now applications. What I mentioned was clinical research, but we have FDA-approved solution. The first one approved was in 2017. That's not a long time ago. And that was a system cloud-based for cardiac MRI analysis, which was one of the most complex imaging, diagnostic imaging. There's a few others. Here it's for much more simple imaging, X-ray of the wrist to detect a wrist fracture. But with the system, you reduce misinterpretation by 50%, which is quite significant. Or for us, neurologists, having this automatic perfusion imaging analysis at the acute stage of stroke to help deciding on thrombectomy. So of September 2018, those were the different solutions that were approved by the FDA, about 15. So that means it's there. And this is one example on the right-hand side, the cardioband for Alive Core, coupled with the Apple Watch to record EKG and detect atrial fibrillation. But more recently, Apple was able to show they could detect atrial fibrillation without EKG, just with a photoplethysmography, the PPG, with a relative high sensitivity and specificity. But on the other hand, those 15 applications, when compared to the 36,000 hits you might have in PubMed by clicking machine learning or deep learning or artificial intelligence, show the huge gap between all the research, all the potential, and what is really available and demonstrated in human. Demonstrated, but not yet in terms of public health benefit for most of the solutions that remains to be shown. The study are ongoing. You can appreciate this Apple Heart study. They've been able to recruit more than 400,000 participants. That's quite a scale. It's another universe. So question number 2, if I'm able to move there, yes, and launch it. It's moving to epilepsy now. And the question is whether AI and machine learning in epilepsy have been primarily used to identify rare disease, analyze data from wearable devices, detect or predict seizure from EEG signal, delineate the epileptogenic zone, decide of the best medical treatment. I'll let you a few seconds. Okay, so there were 56% for response 3, detect or predict seizure, and the other were much less. And you're right, you're perfectly right. This is a PubMed search on those keywords, machine learning, deep learning, AI, and epilepsy or seizure. The graph is looking at all the hit. It's a little bit more than 1,000 over years, but with a steep increase over the last few years. But then if you want to be more selective and look at those publications where these words, or the same query was with the words in the title, then it will be only 32. And most of them were about EEG-based seizure detection or prediction. A few regarding post-operative seizure control prediction based on EEG, or delineated the seizure onset zone, again, based on EEG. But there are obviously other applications. This is from the courtesy of Ingmar Blunke. I told you about pathology, and his group is using now this capacity of machine learning to work on his huge database of epilepsy surgery resected tissue, for which he made a beautiful New England Journal paper recently. And I'm sure we can learn a lot from this new approach in neuropathology. This is just looking at one study in the field of seizure detection using EEG from the group of Andreas Schulz-Bonegger, looking at the different types of method of machine learning and looking at their performance in terms of area under the curve. And you see scores that are quite elevated, around 0.9. And of course, we have one device in epilepsy that has been FDA cleared last December, and that used some type of machine learning, and this is the Embrace for detecting generalized tonic-clonic seizure. Now, if we want to move towards detecting more seizure, potentially all seizures, I think we will need to go to much more complex system, probably record the EEG invasively or non-invasively. There are systems embedded in glasses that are developing on top of the other biosignal you can have at the wrist, and definitely use the machine learning within the embedded system so that it can learn from individual patient seizures. And that's something that we are currently developing, and definitely a big trend in the field. A little bit of advertisement if you're interested in this seizure detection and mobile device with Senator Meninsky. We're organizing the second International Congress on that topic in September in Lausanne. So this is one example of multidimensional data we're talking, not yet there, but we're moving to that stage. And definitely AI will play an important role. The more complex the data, the more multidimensional, the more AI is providing an advantage. And we're talking about the patient data, but also knowledge and bringing the two together, especially knowledge that in system biology becomes so complicated. This was 10 years ago, but look just for the description of the mTOR pathway. So imagine is for epilepsy, want all the knowledge that could be relevant to manage a patient. How much information need to be gathered and organized. And this is the main issue. This is the main issue we're facing. how to organize the data to make AI useful, effective, and performant, and put together the patient data and the knowledge. And for this, there is a methodology that is very effective. It's called the knowledge graph. And it is being used by all major IT companies, Google in particular, since 2012. A little bit complicated to explain, but to make a long story short, rather than having your data tabulated in columns with every variable a column and every line of patient, then you create links, systematic link, semantic link between all the data and all the metadata. And then your AI and machine learning tools can explore all the system, understanding the link between all this information, and that's essential. So that's very much desirable, except that at the moment there's a huge gap between the way we collect and organize data in EHR and what AI will need to put them in a knowledge graph. And of course, there is this view that with data mining, one could fill the gap and pass from EHR to knowledge graph very easily in the future, maybe, definitely not today. So, moving towards clinical practice with this methodology is a challenge. And the challenge is not on the side of the algorithm. This is the easy part. The challenge is on the part of organizing the data, on the one hand, what I just explained, and of course also validating the impact of the solution. And it's complicated and difficult because we're facing a lot of issues, and that's my last slide before the conclusion. Data standardization, we just mentioned it, but there are initiatives to organize this information the same way we have used the DICOM format for harmonizing neuroimaging data in general. There's the issue of data sharing. We need a lot of data to train the system continuously because we want them to improve over time. We need transparency. This is very important. I told you about unsupervised machine learning, but eventually we need to understand how an algorithm, supervised or not for its training, is taking its decision. And in fact, in Europe, through the General Data Protection Regulation, it's mandatory. Article 22 makes it mandatory. It's important because it will be so easy to hide some voluntary or involuntary to hide bias and discrimination under a black box that will decide who get which treatment. You can very easily understand how this could be manipulated. We also need to define how we will measure quality control of the algorithm, and in case of adverse event, what will be the accountability? There's definitely financial issues. Reimbursement is not yet there for most of those solutions, so it hampers the capacity to develop appropriate clinical study at the moment. We need education for us who have to learn on how to use the system. And finally, an appropriate regulation. The FDA has already made a lot of effort. We need the same in Europe to find the right balance between regulatory processes that are compatible with the streamline needed in the field, but also that really secured the solution. So in conclusion, health-directed AI and machine learning are developing fast. You know that, you hear that all the time. Still has limited clinical application and lack of impact assessment on public health for most of them. In epilepsy, they are primarily used for seizure detection at the moment, with also limited clinical application, but I do believe there are major opportunities to optimize epilepsy care. If we want to play a role and to be in the forefront in this field, we have to understand that we need to organize ourselves at the level of the community, not just the few elected that can manipulate those algorithms and make nice publication. And we need, I believe, to develop international effort to get the right model for curating, organizing, and sharing data. Thank you for your attention.
Okay. Thank you, Philippe. I think we don't have time for questions, but everybody will be thinking very carefully about the challenges you put in front of us, and clearly this is going to be the way forward in the next many, many years. Things will go fast, of course. They are speeding up as we talk. The next presentation is from Sanjay Sisodia, Precision Medicine and Epilepsy Therapies of the Future.
Thank you very much, Martin and Sam, for the invitation and for putting together this program, which I think is really well integrated. So we've heard some excellent work on the amount of data and its processing, especially, for example, for epilepsy surgery. I think for precision medicine, we are not there yet, and we can see maybe a way forward. I would say that precision medicine is optimism-rich, but data poor, and I'm going to give some examples of that. There's a huge amount to cover. I'll just give some particular examples that I think bring out important features. As for epilepsy therapies of the future, well, your guess is as good as mine, so I'm going to give you a very personal view of what I think about that. So, a few definitions and a quick summary. Currently, I guess precision medicine is being defined as using a person's genetics, environment, and lifestyle to help determine the best approach to prevent or treat disease. The goal, of course, must be to provide the best available care for each individual. Precision medicine today, I think, is particularly focused on genetics as the tool of the day. But you can see from a lot of the preceding talks that there are other elements that will be brought into how we look after people with epilepsy. And so that definition of precision medicine is likely to change as time goes on. And therapies of the future, well, of course, therapies of the future become therapies of today. New tools and new understanding improve these. And I think we shouldn't ignore the fact that really we've hopefully always been practicing precision medicine. We've hopefully always been providing the best care that we can. So here's an example. This is one particular patient whose onset of epilepsy was at the age of 11 years. He received what we thought were the best medical treatments. His seizures failed to be controlled. He had what we thought was the best MRI at Chalfont, at our own center. We didn't see a lesion. He underwent surgical evaluation. He had stereo EEG. At each stage, we were hoping we were providing the best treatment. He had surgery. It would have been very nice, I think, to apply some of the techniques that we've heard about earlier today. He had a resection. Here's the resection tissue, which showed an unusual form of developmental abnormality with these hyper-autofluorescent neurons. He was briefly seizure-free. Because his seizures returned, we thought we should look into more detail. We looked at his genetics, couldn't find anything. Eventually, he had a whole genome sequence done. That identified a mutation in DEPDC5, which perhaps will bring new treatment options. But at each stage, I would like to think that we had offered the best treatment possible. And genetics may be the tool of the day for precision medicine now, but of course there will be future treatments and future investigations that are available that will change what we think of as precision medicine. And I think we shouldn't be constrained by these thoughts. We shouldn't also be constrained by geography. We know that not all of these things are available all across the world. And I would hope to think that actually precision medicine is not a new technique, is not a new idea. It's something that we've always been doing. Neither should it limit our thinking about how we look after each individual. So, thinking about it today, it's focused on genomics. Genetic discovery is fundamental, of course. It sets the direction, but I would argue it's the start and not the end of the journey, whether that's gene discovery or identifying what one thinks of as the variant responsible for the epilepsy in an individual. We know there are well-established paths to identifying genes, but we also know that sometimes I think precision medicine is conceptualized as a surgical strike. We find the genetic cause, we think it applies to this patient, we think there should be a rational therapy available, and that's the linear process that we think applies. I would argue that it is more than that actually that linear thought doesn't really encompass the multi-standard profile of human diseases, including epilepsy. And in my view, precision medicine can only really be complete if it addresses the whole picture, and I'll give you some examples of my thinking along these lines. So, here are some examples of what we might think of as successes with the current precision medicine paradigm. Those of you who were here in the session before this will have heard about everolimus and other rapamycin derivatives in the treatment of seizures and disease modification associated, for example, with TSC1, TSC2 mutations. There's a lot of good evidence there for that now, but we've also seen how complicated it can be. Here's an example of precision therapy which involves the replacement of a deficient enzyme with some very promising results in this condition for preservation, for example, of motor and other skills. And we all know about the utility of the ketogenic diet for treatment of glucose transporter deficiencies. Here's another example where perhaps it's not so clear how the medication relates specifically to the disease biology, but we know that this treatment, stirupentol, can be very effective, specifically for a particular epilepsy syndrome. Most of the data we have, of course, is relatively poor in terms of the numbers of patients who've actually been treated, but the excitement around this is often big. So we have, for example, how memantine might be effective for epilepsy associated with GRIN2A mutation. We have quite a significant study of the effect of sodium channel blockers in SCN2A associated epilepsies, where we see, for example, that sodium channel blocking drugs can be effective when the disease is of early onset with a good genotype-phenotype correlation, because particular types of mutation seem to cause epilepsies that are of relatively early onset and respond to these sodium channel blockers, whereas later onset disease tend to respond less well. So we have some good examples of how precision medicine approach might apply in specific conditions. And the importance, I think, of this generally is that we're beginning to find these types of mutations also in people who don't have these more severe epilepsies. So it's not just the case that this applies to the developmental and epileptic encephalopathies. We're seeing, for example, from the EPI4K study, that people with otherwise relatively uncomplicated non-acquired focal epilepsies might also have mutations in these same genes. And I think there's an unanswered question here in terms of whether these treatments might also apply to people with these conditions. And that's something that has to be directly tested. And what we see is that as we get more data for each of these conditions, we see that it does become more complicated. So there were some early reports of the utility of quinidine associated with gain-of-function mutations causing epilepsy due to mutations in KCNT1. But as we have more data, we're seeing that actually many patients don't get the quinidine, and the patients who do, not all respond. There might be more sophisticated genotype-phenotype correlations. It might be that mutations in specific parts of the gene produce epilepsies that are more responsive to quinidine. So the more data that become available, the more nuanced the picture clearly becomes. And here's an example in a little bit more detail. I'm grateful to Holger Löscher and his team for providing this data and sharing it today. So we know that mutations affecting this protein, KCNA2, when they're of gain of function or mixed effects on the function of the protein, can cause severe epilepsies. And Holger and others have shown that 4-aminopyridine can be an effective agent to reverse this gain of function. This is particularly nicely shown in vitro. And this now is a study of roughly 20 patients who've been exposed to 4-aminopyridine with gain of function and similar mutations in KCNA2. And you can see that not only are the seizures effectively controlled for some individuals, so green is a good outcome, the more green it is, the better outcome, but also other aspects of the condition may also be well treated. And this is, I think, an important aspect of precision medicine. We need to be thinking beyond the seizures alone. So here you have, for example, an effect on the EEG in a good proportion of patients, an effect on ataxia, and on cognitive abilities. But we also have to see that there are patients here who are not responding. And there's one patient, and this happens to be my patient, who actually got worse. Now, in my view, if we're saying that we have a precision medicine approach with a surgical strike, if you like, for treatment of the seizures, because we understand the underlying biology, then we should also be able to explain why this patient's seizures got worse. There should be a precise explanation, in my view, for precision medicine failing. Otherwise, we're back to the idea of large clinical trials and blockbuster drugs. We need to know exactly what's going on. And it may be, of course, that there is more than just this single mutation which is relevant for the disease. We're not just single mutations, we're not single variants, we are genomes, and more than that, of course. And so this is an interesting study from a Japanese group recently published, which showed that in people, so we're looking, I think, specifically at this sector here, in people with severe epilepsies who have mutations in genes associated with epileptic encephalopathies and developmental and epileptic encephalopathies, that a proportion of these patients, a significant proportion of these patients, also had mutations in other genes. Now, some of these other genes may turn out to be genes for epileptic encephalopathy or developmental and epileptic encephalopathies, but there may also be genes that are not obviously related to these conditions, but that nevertheless have an impact on disease presentation and response to treatment. So we do need to be thinking, if we're thinking about a precision medicine approach, not only about looking at the patient as a whole, but also looking at the genome in more detail. And here are some examples. So here we see a Manhattan plot which identified variations associated with this gene being associated with the risk of developing a mild rash, a maculopapular eruption on exposure to phenytoin. Now, of course, it could be possible that any patient with epilepsy might have not only a variant that is responsible for their epilepsy, but also the variant here that might be responsible for developing a rash on exposure to phenytoin. That's only identified clinically when they're exposed to phenytoin, and so if this patient doesn't have epilepsy, this variant might not necessarily become apparent. But there must be other variants across the genome which are likely to influence response to treatment and other outcomes in the epilepsies. So we do need to think more broadly about the genome and not just stop with the first variant. And here's another example. This is a patient who had Unruh-Lundborg disease with biallelic mutation in CSTB. He kept getting fractures, which was attributed to his chronic therapy with anti-epileptic drugs and his immobility and the various other factors we know about. But what was interesting was that none of these fractures were associated with an increase in alkaline phosphatase. And actually, looking further into this, a mutation was identified in an entirely separate gene, which also increases the risk of bone fractures. So here we have a complicated picture, people with more than one mutation that might be responsible for the overall clinical phenotype. So we do need to think more carefully and explore the genome more widely. And I think we also need to think about applying these data in the way that we've heard about, for example, for epilepsy surgery. So we have this currently linear surgical strike approach. We identify the mutation here, for example, in two brothers. Mutations were identified, homozygous mutations were identified in this gene, which is responsible for creatine synthesis. So this leads to this linear idea that we can simply replace the creatine, which of course was done. The patient's seizures stopped. But actually, this did not lead to an improvement in quality of life, because what happened was that the intellectual disability that the patients had and the other problems that the patients had were not addressed. And what actually happened was that the relief from seizures meant that behavioral difficulties became much more apparent and were expressed. And in fact, although the patients were taken off anti-epileptic drugs because their seizures stopped, they ended up going back on them for behavioral reasons. So if we're thinking about how we manage genetic data in a precision medicine approach, we need to think more widely. In epilepsy surgery, we think about what factors, what would happen from prior knowledge, what might happen to the outcome if people didn't become free of seizures. Maybe in some genetic epilepsies, we need to think more broadly about what might happen if people do become free of seizures. So I would argue actually for the sort of algorithmic approach to the management of genetic data that we've heard about, for example, for epilepsy surgery. It's not just gene, mutation, physiology, response. So here's another example of that, of thinking more broadly. This is the set of conditions known as the ATP1A3-related diseases. Mutations in this gene affect this protein, which is a sodium-potassium exchange pump, essential for the physiology of all excitable cells. It's a rare condition in which we see both fixed and dynamic features, and seizures in about 50% of people. So people get paroxysmal hemiparesis, hemiplegia, paroxysmal dystonia, and they also get seizures, but they also get other things. So for example, let's look at this video. This is a patient who has alternating hemiplegia of childhood with a mutation ATP1A3. We could spend a little time discussing what this is, but it's not a hemiparetic episode. It's not a seizure. It's not a dystonic episode. In fact, what you really want to do for this person is to lie them flat on the floor. This patient's probably having a syncopal episode. And if you think about ATP1A3, if you just look at the biology of the gene, we know that actually it's not just expressed in the brain, it's also expressed in other organs. It's expressed in the heart, peripheral nerve, muscle. Here's some heart tissue with stain for ATP1A3. And what we see now in a study that we've just undertaken is that actually people who have this condition have heart abnormalities, heart rhythm abnormalities with prolonged periods of asystole seen in the same proportion of people as you see in inherited cardiac channelopathies. So this disease, which was initially studied as a brain disease, is not just a brain disease, it's also a heart disease and probably also a muscle disease and a nerve disease. And if we're thinking about precision medicine, then we need to be exploring the consequences of mutations that we identify across the entire system, not just in the brain. This is part of an overall evaluation and management from a precision medicine perspective. And this really makes, I think, our work richer. Because one of the things that gene discovery does from a precision medicine perspective is that it brings people together. So you will all have seen, I expect, people in whom a mutation has been identified. As soon as people are out of the door, they will be looking for other people with mutations in the same disease. They will set up Facebook groups and other organizations which link together people who have the same condition. So we've seen this especially for this condition, alternating hemiplegia of childhood, where discovery of the mutations of the gene that was, discovery of the gene that was mutated in this condition brought together an existing community of scientists who are working on this protein, clinicians and basic scientists interested in this disease, and also the patients themselves. And this has led now, for example, to annual meetings of people with, interested in this condition, where we have a direct interaction between the patients, the carers, the families, the scientists, the clinicians, which really helps focus and drive forward the science. And so I would argue this is also part of a precision medicine approach, because actually you can get a lot further by taking into account the knowledge that the family bring as well as the knowledge we have from the science. And this is, I think, an element that we can add to Philippe's idea of the artificial intelligence approach. So we can do fantastic things now with the genome. We can do fantastic things with the algorithms, and we can do great things with machine learning. But I would argue that the one thing that we are perhaps lagging behind in is in the phenotype. As clinicians, we have excellent abilities to phenotype the clinical aspects. But I would argue that there are also aspects of the phenotype that we also need to access that we're not yet doing. And I'm just going to give you one particular example that we're applying in order to try and get a better understanding of what's going on. So this is transcranial magnetic stimulation. Many of you are familiar with this. You stimulate the cortex using a magnetic pulse, and then you can record various outputs, here EMG, but also EEG. If you just stimulate the cortex and record from the muscle, you get an evoked potential. You can do various things to make that more sophisticated, so you can have two pulses close together, for example, just milliseconds apart, and that makes the evoked potential much smaller. If you then look at the ratio of this pulse to this pulse, you can see it should be less than 1. So this is what you'd expect in the healthy brain. So here is the line of normality, if you like. Below this is normal for this measure, SICI. Above this is abnormal. If you look at healthy controls or people with epilepsy who don't have Dravet syndrome, then you'll see that it is below 1, which is what you'd expect. Now, from our understanding of Dravet syndrome currently, we would expect that there is some degree of loss of inhibition in individuals who have Dravet syndrome. That's what we see simplistically from animal models. And here we see in patients who have typical Dravet syndrome with the core phenotype and the expected response to anti-epileptic drugs, that actually you do see a loss of inhibition on this simple measure. So we have a deeper cortical neurophysiological phenotype here of what's going on. GEFS plus, also associated with SCN1A mutation in these cases, you don't see that loss of inhibition. And this parallels the clinical differences between these two conditions. And in this red box, we have a group of patients who have the core phenotype of Dravet syndrome, but who have unusual responses to anti-seizure drugs. They might, for example, be responding to sodium channel blocking drugs. And we see that their neurophysiological profile is different. So we can begin to make the phenotype deeper using other tools that we're not maybe currently accessing as much as we might. And here's another example of the same thing. This is TMS, this time EEG, so recording EEG signal as the output, stimulating here, and we're applying this specifically, and you'll see how this two-dimensional projection of the dipole response to this perturbation, see how this changes over time. We're applying this to try to improve treatment prediction in people with Dravet syndrome, in particular, in fact, in this case, for cannabidiol. So there are other things that I think we can put together, and I think this comes back to what Philippe was saying about using multiple layers of data. I'll just skip very quickly through this. This is an example of using MRI data correlated with gene expression data to look at regions of cortical thinning in the brain and seeing what patterns of gene expression match this, coming up eventually with systems that might be affected that lead to the cortical thinning, eventually leading to processes that we can manipulate. So this is putting together genetic data, imaging data, gene expression data, animal model data to get a better understanding of a phenotype, in this case, that is relatively poorly studied, I think, which is disease progression in the epilepsies. So you can see, in my view, that precision medicine really needs to be more sophisticated and more complex and more nuanced than it is currently, than our current linear approach is. And this, I think, will take us to epilepsy therapies of the future. I've just listed some things here. And many of you will be working on different ideas to think about how we might deal with seizures and epileptogenesis in the future. And I think we can learn from surgical approaches. We can learn from genomically driven precision medicine. We need to be able to integrate many layers of information, and we've heard about how that might be possible. In my own view, phenotype remains the key here. We need to understand the phenotype in each individual who's in front of us and maybe use other techniques, but we still need to remember what's particularly affecting our individual patients. And I suppose one of the big debates in epilepsy therapies of the future is whether we're thinking about preventing epileptogenesis or treating epilepsy or both. Of course, I guess long-standing ideas would suggest that it's better to prevent than to treat or to cure, certainly probably more efficient and better in terms of outcomes. But we want to be working on data. We want to be thinking about hard evidence to drive our perspectives. And so I'm just going to end with one final thing about hard evidence for the future. None of us really know how we're going to be treating epilepsy in the future, but something we do know about the future is climate change. Now, you might think, why are we going to be discussing climate change in the talk on epilepsies? Because in my view, climate change will affect epilepsies. If we're thinking about hard data, this is one of the best things we know about the future, that the climate will change. And our own experience in real life is that probably climate is changing. And here are some examples of how it might affect epilepsy. So this is data from Ingrid Scheffer, who reported a patient with Dravet syndrome who had been well controlled on anti-epileptic drugs, who then went out walking on one of the hottest days they'd had in Melbourne for many years and was found deceased, probably due to SUDEP. This patient had an SCN1A mutation. We know that the SCN1A protein, its function is exquisitely sensitive to temperature. And we've heard from Mark in his talk earlier on about how temperature and humidity can be associated with seizure patterns. These are things that are going to change. We know, for example, that the range of vectors that carry infections that can cause epilepsy will also change. And there are predictions that by 2050, even in London, we will be seeing for a few months of the year mosquitoes that carry these infections being active. And this is just with a 1 degree rise in global temperatures. Along with this, we will see a loss of biodiversity. So this is data from Camilla Esguera from Norway. She had a postdoctoral student who related to her that in the Cameroon, where she came from, there was an extract of a particular plant that seemed to have an effect on seizures. Okay, so, and we're going to lose these kinds of plants, I guess, with changes in biodiversity associated with climate change. So I'm going to just end there and thank all the people who've contributed to this work and the funders for this work. Thank you very much.
Thank you very much for a fascinating tour of this area of development. We have no time for questions, unfortunately. Need to move on to our next and last speaker. You know, the future also involves treatment of epilepsy where there are few resources. And this is an important aspect of epilepsy care. And to talk to us about that aspect is Dr. Angelina Kakusa, who's going to talk about epilepsy care in resource-limited countries and what the future holds.
Good morning, everyone. Thank you very much, Professor Sam Wiebe and Professor Martin Brodie, for having invited me to present the session or the talk on epilepsy in low-resource countries. What does the future hold? As you'll note, my talk is going to be quite different from what you've been hearing, and this is more of a public health approach. One in 10 people worldwide have at least a first seizure in their lifetime. And we know that epilepsy is one of the oldest common neurological diseases known to mankind. It knows no geographical age, racial boundary, sexual or social boundaries, and it can begin at any age. It's characterized by an enduring predisposition to generate epileptic seizures. Now, with 90% of the people who have epilepsy living in low and middle income countries, you can see that the burden is quite high in the low and income countries. Overall, sub-Saharan Africa is estimated to have at least 10 million persons living with epilepsy. Regarding the incidence, it has been estimated that in the low-income countries, it's almost double that in the high-income countries. And according to a WHO report, the incidence of epilepsy in high-income countries is higher in the age group of 30 to 50 years, in contrast to the younger age group in the low and middle-income countries. So what are these low-resource countries? Looking at this map, you see that the countries that are shaded orange are the low-middle-income countries, and those that are in a dark brown are the low-income countries. Majority are found in Africa and Asia. What is the state of epilepsy care in these low-resource settings? You'll note that since the Millennium Declaration was signed in 2000, the general government expenditure on health as the total government expenditure is very low in these low-income countries. People use health services around 150 million each year, but they suffer from financial hardship because they have to pay out of their own pockets at the time when they receive care, and 100 million people are pushed into poverty as a result. There is inequity in health expenditure. You find that health spending in low-income countries, on average, though has increased at 6% annually, there's still a large gap when you compare this with the high-income countries. Health spending, as you can see in this graph, a recent report by WHO, shows that low-income countries, though they have a high current health expenditure, and they're compared to their GDP, you find that with high-income countries, their expenditure is much less. When we look at the global population by health expenditure, only 20% of the world's population live in high-income countries, yet these countries account for close to 80% of the global health spending. Whereas the top 10 countries that spend the US dollars of about 5,000 or more in 2016 were in high-income countries, and the bottom 10 countries that spent less than US dollars 30 were in the low-income countries. So this disparity exists and the gap becomes wider. Poverty is trapping many individuals in a cycle of poor health, and there is, in addition, shortage of health worker cadres. You find that the shortage of trained health workers and rehabilitation personnel for epilepsy is unequal in the region. When you look at this map of the World Health Organization showing the mental health personnel in the low and middle income countries, you'll note that the mental health workforce is limited in the low income countries. This worker shortage derives from a combination of underproduction, internal maldistribution, immigration of trained workers, to mention but a few. This scarcity of trained physicians and inefficiency of low cadre workforce affects the way that they're going to manage conditions such as epilepsy. And the World Health Organization estimates that this global shortage is going to continue and expand from 12 million to 18 million by 2030. Furthermore, there are disparities in the distribution of health amenities. You find that in the urban area, compared to the rural, there are disparities. A country like Brazil, for example, you find within a country, the treatment gap in the urban area is about 38%, and in the rural area is about 67%. when you look at access to supportive investigations, for example, like continuous video EEG monitoring, CT scan, MRI, in this context, many of these facilities are not uniform in the low-income countries. There is also limited access to medication. Despite the presence of effective anti-epileptic drugs, there is a substantial treatment gap. And according to the recent report, you find that more than 3 in 4 persons are not on medication, have no access to medication. So you find that medication in epilepsy is a sore problem. There's limited human and financial resources, misconceptions and stigmas surrounding epilepsy, and lack of access to many of these drugs. Furthermore, the community is not aware of these problems. You find that lack of awareness from lack of information on education about epilepsy is very prevalent amongst the family members and amongst the community, resulting in many people with epilepsy and their families suffering from stigma and discrimination. Quickly looking at the risk factors for epilepsy in low-resource countries, we find that adverse perinatal events, infections such as malaria, have been linked to epilepsy. And we found out that the risk of developing epilepsy is greater among those with cerebral malaria compared to those which were non-exposed. Studies done by Ngogu, and also a study that we did in a hospital in Uganda, in Mulago, we found that more than half of the children who had cerebral malaria developed epilepsy. Gretchen Barbeck, in addition, also noted that 12 of 132 children who had cerebral malaria also developed epilepsy versus none in the controls. Parasites are another big issue regarding epilepsy in low-income countries. Adults who've been exposed to parasitic diseases are 1.5 to 3 times more likely to have epilepsy than those who have not. And those who have more than one parasite, the risk is increased. For example, if you have Toxoplasma gondii and Onchocerca volvulus, you are more at risk than one who has another combination. Neuropsystocytosis infection has also been considered as an underlying cause of epilepsy, especially among patients with late-onset seizures. And campaigns to increase awareness of this infection are underway. This is just showing you a diagram where there's a brain that is infected with neurocysticercosis cysts. Traumatic brain injury is also another common cause of brain injury that we find in low-income countries due to lack of traffic regulation and failure to enforce laws to protect the individuals. Brain damage can also result from accidents, assault, and injury in war or violent sport. Cerebrovascular disease and stroke is another issue that is a risk factor in low-income countries. With that scenario, this is the scenario that we find in low-income countries. What would the future be like in low-income countries regarding epilepsy care? Looking at the future, in order to try to cater for all those issues that I have previously described, we'll need to ensure to task shift or share to optimize health worker performance. Task shifting is a process of delegation in which tasks are shifted where appropriate to less specialized healthcare workers are involved. Community-based rehabilitation is one of these examples. It produces sufficient numbers of locally skilled workers with the right mix of required skills, enabling them to undertake activities for the service and making it accessible to diverse populations. A recent study by Van Deysen, which was done in Guinea-Bissau, showed us an example of how this can work. They utilized community-based approach, which was done by trained community volunteers. They were able to effectively bridge the epilepsy treatment gap in this poor resource setting in Guinea-Bissau by having these community workers having frequent checkups, looking through the patients, and the cost of treatment and monitoring of a single person with epilepsy using these community health workers was less than $1. So looking forwards in low-income countries, this may be one of the ways to go. When we look at neuroimaging, it's very impressive to see what is being done in the high-income countries. But you have to remember that in the low-income countries, neuroimaging, even having an MRI scan in a referral hospital where I work, is non-existent. But in the future, this neuroimaging can be adopted as a standard of care for epilepsy. And these investigations, together with the others that are portrayed, will further facilitate screening of patients for subsequent neurosurgical care. We also hope that in the future, we'll have legislation of epilepsy as a disease of importance by respective governments. We know that at the moment, we lack laws and legislation as effective means to implement population-level interventions in epilepsy. This now results in stigma, it results in misinformation, because people are not aware of what they should do. If we are to encourage the use of insecticide-treated mosquito nets, that is going to show that malaria is minimized, infection control stepped up for neurocysticercosis, injury prevention, ensuring that helmets for motorbikes and their riders are insured, immunization, improvement in maternal and newborn care to minimize perinatal insults, preserving cardiovascular and cerebrovascular health. These are just interventions that can not cost much, but can be able to eliminate those risk factors that can then improve on epilepsy care in low-income countries. Also, you may note that genetic studies, especially like in a country like Africa, are very minimal regarding epilepsy. But in the future, hopefully there will be discovery of unique, important epilepsy-associated genotypes, because we know that 60% of epilepsy etiology is unknown. Now, these new genes and variants underlying disease in a range of epilepsy phenotypes may be ways in which we can try to maybe guide in terms of treatment and also help us in terms of comparing what is in the high income and in the low income. The relevance of these epilepsy genetics in patient care is especially evident among infants with early onset epilepsies and where early genetic testing can confirm diagnosis and direct treatment, potentially improving the prognosis and quality of life of our patients. It's also possible that in the future we shall have utilization of modern technology for epilepsy care in terms of e-health and telemedicine. These methods have been noted to be promising in terms of producing ways in which you can try to make widespread availability of services closer to the people, especially in remote areas. But this is going to be based on the assumption that infrastructure will have improved, stability of electricity will be present, there will be fast internet connectivity, and adequate funding as well. There will also be a rise in mobile phone apps, possibly because there will be the mobile phone penetrance in most of the low-income countries is on the rise, with over 60% in low-income countries having high mobile app penetrance. So this can be a platform that can be used to either spread messages, to be able to connect many individuals, give them the information that they need, monitor treatment. At the moment, some patients come with their videos on their phone apps, on their phones, to show you what their child has been suffering from, and it makes it easier for you to be able to classify this child. There's also going to be a mode of obtaining health information on epilepsy, which will be much different, using Facebook, Twitter, and the like. Also, the strengthening of health systems is critical in the improvement of epilepsy care in low-income countries. When there's strengthening of health systems, then you know that the rural areas are also going to be empowered to take care of these patients. But we need increased government expenditure in terms of trying to alleviate poverty, create more jobs, increase productivity, and inclusive economic growth and ensuring healthier and safer, just societies. We also have the advantage of having the development of new anti-epileptic drugs. There are many of our colleagues in Africa and in Asia, China, to mention but a few, and Cameroon, who are using a lot of herbal medications to try to develop new anti-epileptic drugs. The development of new anti-epileptic drugs from traditional medicine may be also another development in the future. Innovative strategies to increase on the availability of anti-epileptic drugs will help in reducing the treatment gap. We also have to consider engagement with alternative health providers. We cannot deny the fact that the majority of people, many people in the low resource settings, go to the traditional healers, go to those people with alternative medicine. So opening up dialogue and engaging these traditional healers in providing epilepsy care is one of the ways to go. These are recognized community medical professionals who are respected by the communities, and they may provide alternative ways to deliver the much needed health access care for these patients with epilepsy. So the future for epilepsy in low-income countries is still unraveling. We need increased and committed investment in health expenditure by our respective governments. We need to have utilization of the rapidly growing technology to ensure maximum patient benefit. We need to integrate epilepsy care into primary health care to ensure that all people with epilepsy have access to quality and affordable treatment and services. And we need to legislate for epilepsy to provide a promising future for people with epilepsy. Thank you for listening.
Thank you very much, Angelina, for bringing us back down to earth. It's very nice to see the science, but the real world is a little bit behind that. Please, do we have time for a question or two or a comment? Okay. Are you collecting data for gene analysis? Because the guys in the audience and the guys in the podium here would, I'm sure, love to have
There is a group, I'm not part of that group, but there's a group in South Africa that is started to collect data on genes in epilepsy. And also we did a prevalence study on 5 sites in Africa, and we've taken some of the samples for genetic analysis. So we hope that in the future we shall be having quite a number of phenotypes. We need to know, and it will be exciting to know what's happening with a diverse population in Africa.
Yeah. I won't ask you whether you think it's going to be very different from elsewhere, but...
That's quite a tricky question, but...
Please, we have another question here.
Thank you so much for the excellent presentation. I would like to know if you spoke about the herbs from Cameroon.
Yes.
It might be the future of epilepsy surgery, of epilepsy treatment when we look at the cost. Yes. Are those herbs already available? Is it a place where we can, or somebody we can contact to have access to those herbs? Do you have some study validating the effect of the herbs?
Well, there are so many studies going on in Cameroon regarding herbal medication. And in fact, one of our own won a prize for a drug that she was trying to extract from the plant. She's a lady from Ghana who was trying to extract medicine that had epileptic properties from a plant to try to see how she can manage to treat status epilepticus. Now, the challenge we have, development of a drug is not as simple as you get the plant, you extract the compound, and then you're able to use it. It goes through a series of processes. And we know that in Africa, even in Asia, we really have a wealth of information. The flora, the fauna, we have a lot of these plants that have anti-epileptic potential. So looking forward, we hopefully in the future, we may have faster means in which we can be able to extract those plant medications and be able to use them. We don't know. At the moment, I do not have any concoction with me regarding anti-epileptic medication, but they are traditional healers in respective countries who have these concoctions. They're not able to give you the formula. They'll just tell you, take it and use it, but I can't give you my secret.
Thank you so much.
Thank you very much. I'm all for concoctions myself. Thank you all for coming. Thank you, Angelina, and thank you to the rest of the speakers and my partner here. We've had a super session and with lots to think about, and we hope that you'll enjoy the rest of the Congress as much as I'm sure you enjoyed this session. Thank you very much.